So we talked about what can happen if you don't have a good transition. So what are some goals we can set up in order to have a good transition? So the target being a great transition where the patient maintains their continuity of care and their medications and they don't have disease flares. So we want to be able to maintain disease control, promote self-management, preserve quality of life, and ensure continuity. Now, how do we do that? We're going to talk a little bit more about that. But I want to focus in a little bit on self-management. Self-management is highly variable, I think, among the pediatric rheumatology community. When patients are seen in pediatric rheumatology, it's not as expected. Whereas in adult care, it's expected. You have to be able to take care of yourself. And our patients who do the best have high self-efficacy and can employ those self-management strategies themselves. So in order to develop those self-management strategies, though, they should have help along the way developing those and even knowing what they can do. So some of our adult patients may know how to self-manage by getting good sleep, taking care of themselves, getting good exercise on a regular basis, eating healthy, taking their medications. But someone has to tell people how to do that. And a lot of young people are also now exploring their independence and going to go out late at night, not sleep as well. Uh, Actually, it's kind of fun to watch them learn those lessons in that first year or two of college. Okay, so how do we prepare for that journey? The ideal is that we have early prep for transition. So this is setting expectations about what adult rheumatology is going to be like. What does it feel like to be in adult rheumatology practice as a patient? It's going to feel a little cold compared to the hand-holding, warm environment of pediatric rheumatology. This is also the time to start talking about self-management strategies, talking about symptoms and what influences symptoms, how to, like, why sleep is really important for arthritis, for example, or why eating healthy is important and how to start building in those habits early. Also recognizing what does lead to flares for an individual person so that they can avoid those flares. Then transfer usually happens around ages 16 to 21. Most of the time it's going to be after 18 in the United States, but we occasionally will transition patients early. One example is if a patient has, that there's siblings. And so I have taken out a patient who was 16 and her sister who was 18 and followed both of them so that they could do appointments on the same days. So they transitioned together. And then through that transition, there's a few things that can make that go even better. And then they'll be fully entrusted to the adult rheumatologist after the transition period. So there's a few different models for that transition period of that age 16 to 21. One is a direct transition, like I am seeing the pediatric, or the patient is seeing the pediatric rheumatologist, and then all of a sudden they switch over to the adult rheumatologist, and that's a direct transition. There may be a progressive transition. So we do this between Penn and CHOP, our children's hospital next door. So they may see me for one visit and then they go back to pediatric rheumatology. So they have another visit there. It's kind of nice because they can then debrief how it was and what they need to take away and how they learned from that. And the pediatric rheumatologist then can communicate with me and say, hey, they found this hard. What's a strategy they can use to help manage that? So they go back and forth a couple times before they finally sit with me. And then the shared transition is that they're seeing both providers continuously. So every 6 months, seeing both or staggered for a period of time. I think that's less common, but the progressive transition, oh, sorry, that's the first one. Progressive transition with combined visits is when the adult rheumatologist and pediatric rheumatologist see people together. That doesn't happen very often, especially for us because we're in two totally separate hospitals, which are two totally separate entities and bill separately, all those kinds of things. So why is transition so hard for patients? Well, here you see this very kind looking Dr. Angel, pediatric rheumatology on the one side, and then the very busy down to the business adult rheumatologist on the right side. And I think I sometimes look like Dr. Angel, but at the same time, I'm down to business. We're moving from patient to patient to patient, and we got to get things done. And I can't sit and talk with the parent for an hour because that's what they were used to in the pediatric rheumatology clinic potentially. So things move a lot faster. We're right to the point. We have the questions, you answer the questions, you tell us what you need. We do review systems, we go through the exam, and then we talk about what's next in terms of therapy. So I think that even just the shortened visit and more compressed direct management is a little more challenging for people when they come in. For us, one of the hard parts is knowing where they came from and what they experienced before. We have to remember that as the adult rheumatologist. Uh, I forget that myself sometimes. I think of them as just having seen another rheumatologist, like switching adult rheumatologists, so they're used to the system, but they are totally not used to this system. Uh, this is one where we'll talk about IBD versus rheumatology. It helps when they're transitioning into two places at one time. So one of us that gets them second sometimes has it easier. So as we're starting to think about that patient sitting in front of us, not as the adult who's already had a different rheumatologist and switching to us, but as an adolescent, we can then put in a kind of have a new framework for how we're thinking about that patient. This is a course in change management. I mean, we are adolescents are going through change management. There's cool as a parent of adolescents. There's a lot of cool things happening in the brain at that time that's making them push away a little bit more toward independence, and that's why we have this idea of the teenager who's kind of pushing all the adults away. That's just normal brain behavior, helping them try to learn how to get some autonomy. But this is a big change for them, and so having a background in some change management and think about how to show them how to having some compassion for them going through that change is important. Understanding their need for autonomy is even greater than adults. It's a they need some lessons in how to be autonomous, and they need to feel like they have this sense of control. So giving them that sense of control and autonomy is important, but also making sure that they feel like they belong. It's an interesting balance that we have to strike, and that means something different for every single patient. So for one patient, it might be that the autonomy is being in the room by themselves with you. And so they're having their own visit together. And if the parent is there, they can call in as we discuss everything. So me and the patient have discussed things first. Then we bring the parent in so that they feel like it's they're keeping everybody in the loop, and they if they feel uncomfortable with some decision, mom or dad is on the phone or something, and then we can actually, have that conversation all together. But they have the autonomy and control to say anything they want to say up front, and then they can make the decision at the end of the day. And so that might be one example of how to give the patient some autonomy and sense of control. But this may be different for every patient. Support. So the other piece that we forget as the adult provider is that they are navigating a totally different system now. Adult medicine is complex. There's many moving pieces. In the United States, they're not only navigating their actual visit with you, but how to call and make an appointment, how to use the app. That might be different than the app they use for their pediatrician. Knowing from clinic to clinic is always different too. Knowing how to interact with the staff and who are the staff. Will you talk with a nurse first and then the nurse practitioner and then the doctor? How does that all go? So just understanding the system and helping them understand that system. The medical knowledge, it's helpful to start talking through with them the different pathophysiology in a patient-facing way. So one of the things that I do is I'm talking about therapy options. Is I draw out the joint, draw out the different cytokines like where's TNF, IL-17, interleukin-23, how they relate together, and then where our therapies are targeting. And that may not stick, but it's making them part of the process, and then they can go back and read more. I do find that some of these, especially university students, will go off and actually read more, and then they come back with really good questions sometimes. We have to be aware of school and work transitions. So this is going to be another hard piece, especially in the United States. Again, we have insurance, and so our insurance covers you up to age 26 on your parents' insurance, and then you transition off. There may be reasons that you transition off earlier to work, to a work-related insurance program. And so that's going to change how they get therapies. Knowing how to figure out if the therapy is going to be covered is challenging. So that may be one thing. Also, as they're going from undergrad to graduate school or off to a job, that's just another transition they're going to Their life is changing, so now they have to fit in their different providers and how they're doing with their healthcare, but also, their healthy lifestyle habits. So you might have to help them think through those. Mental health, this is a really big issue. We know that depression and anxiety decrease likelihood of treatment success in patients with spondyloarthritis, as one example, psoriatic arthritis and axSpA, I think RA and other diseases too. So really, really important to take care of this. Also, these patients may be set up for central sensitization later if they're not addressing the mental health. And then managing social life and maybe even stigma is something that may be different from an adolescent to an adult. Adolescents are sharply focused on stigma or social life or what things look like to other people. And so it's important to help them think through that too. So for another example of that is that for a patient who has psoriasis and arthritis, the psoriasis may be even more important to them than the joints. As a rheumatologist, sometimes we don't intuitively understand that, but this is where those decisions may be different for an adolescent, and you have to have that conversation with them too. So challenges, I've kind of talked through some of these in many other pieces of this already, but managing a chronic medical condition as a young person and thinking about your life ahead, having children, getting married, those kinds of things, that's where therapy can be really helpful and helping them create those frameworks and having positive, optimistic thoughts about the future. Responsibility, some people need more help with that than others. Self-management, teaching them those strategies or helping them find places to learn more about that. Managing their new autonomy or perceived autonomy, but not yet ready for autonomy, that's even harder. And then developmental transitions as they're moving from one goal to another. So all those things are hard. And again, young adults are particularly increased risk for loss to follow-up, so making sure there's some kind of warm handoff really does help. Uh, and then I already mentioned this as well, but there's rheumatology shortages in the US. This is something that is really difficult to navigate for adolescents. And so, especially as they're making that transition, that's where the pediatric rheumatologist, getting them started in that process and setting up an appointment 6 to 12 months in advance is really helpful. Who's most at risk for a poor transition? Patients with less active disease because they think they don't need the rheumatologist. So they go away, they're feeling good, and then they flare because they never followed up. So that was not intuitive to me the first time. Boys, age, so 16, maybe worse than 20s, and then motivation and activation of patients, which makes sense. How do we make transition smoother? Establish readiness. So start assessing for readiness, build awareness that there is a transition coming in the next couple years. Utilize resources. There's plenty of resources. I think I have a reference to those in one of the next slides. Educate patients on the differences of care. So we have like a talk that the pediatric rheumatologist gives the kids before they transition over so they know what it's going to be like. Set realistic expectations for both patients and parents. And the parents to me are the important ones because they can be even more anxious and more difficult in the adult rheumatology office sometimes. And then communicate between rheumatologists so that we know what's happening on both sides and offer an opportunity to go back. So I think that's actually really helpful is to do the back and forth a couple times and then keep that communication open so that they get comfortable. So it's not just a jump over. What can we as the adult rheumatologist do? Recognize the needs of adolescents, introduce the entire patient care team. So if you can, introduce them to the nurse, introduce them to the nurse practitioner, introduce them to the front desk, show them where the lab is, show them where the radiology is. Find resources for them online. So in the United States, we have a platform called Creaky Joints where they can read all about things. And that's a nice set of resources we can show them. Watch out for financial barriers. They don't know about these. These also often creep up quickly and they may not be aware, especially that cliffhanger at age 26 for some of our patients. Having a transition clinic can really help. We have that for some of our lupus patients. And then create shared protocols for how things happen in your clinic if you can. So here's some different resources. There's this partner steps. American College of Rheumatology has certain resources. EULAR has resources. There's the 6 core elements. So if you Google any of these, track is a questionnaire that tells how ready patients are. There's youth workers, and then some clinics that have liaisons that help with that transition so they can be a point of contact between all the parties involved. This is an example of the ACR pediatric to adult care transition. So that's here if you want, they have a transition letter, a transition policy. So it's just some example templates to work with from the pediatric side. And they have one for the adult side too. So what are some remaining gaps? Adult physician appreciation of adolescent needs. We're not educated on adolescents. We don't really know about these guys unless we have them as children. So uh, getting used to what they need is really important. And again, that autonomy is a big one. Huge variability across health systems, and it's really hard to educate them about this variability because it is so different. Limited long-term follow-up of transition model studies. There's a lot of studies looking at models, but they're very short-term. We don't really know what happens in the long term. And then care coordination is in short supply, and it costs money. So in the United States, we don't have enough of these people. So back to Ben, I have a number of Bens in my clinic, and I love these guys because you end up caring for them for a relatively short period of time because they go through college and then they go off and they get a job somewhere. But it's such a fun time because they're learning their own disease, and we get to kind of help them figure out how they're going to manage their disease for the rest of their life and settle into that. So they also go through fun things like getting engaged and all those kinds of pieces. So I do hope you get to take care of some of these kids. So conclusions, create a structured transition plan from pediatrics to adult. Ideally, there's a transition and the adult and pediatric rheumatology providers know each other and actually can create a warm handoff, meaning that we can talk about them before. Teach patients independence and self-management strategies early, ideally in the pediatric rheumatology clinic, and then engage families in the process. And that means engaging parents to let them know that their kid is now the owner of their medical care. So with that, I will turn it back over to Pooja.